Hi, good evening once again. I hope you've had a reasonably pleasant day, although being at work, probably not. My name's Rob Ellett, and I'm going to take you through a series of slides which hopefully will explain some of the nuances for the new emergency planning arrangements within the health sector. You will see at the top of your screen you've got the option to send in a chat question in the box at the top of the screen, and also at the end of the presentation I shall allow some time for you to be able to submit some questions to me, and hopefully I can answer them. For those of you who may not have met me or know me, my original background was within a UK fire service, and on leaving that I spent some time working for an engineering company in Washington DC, and then some time with one of the acute trusts in Hull. So I've got some affinity there with the NHS. Following that, I worked for just over 9 years here at the Emergency Planning College as a course director, managing a portfolio of their courses. And then in 2008 decided to work for myself, and one of my first big opportunities was to spend a year at the Department of Health down in Whitehall working with their emergency planning team. So that's me. We're going to go through some slides which, as I say, will hopefully look at the new EPRR, Emergency Preparedness, Resilience and Response Arrangements for the new look NHS as we go forward. Some have made the transition already. Of course, you will know that the cut-off date is the 1st of April. I'm sure you agree with me that they may have chosen a better date, but there we have it. So off we go, folks, and as I say, any questions, if you want to stick them on the chat box or leave them till the end, that's absolutely fine by me. So I think for those of you who are listening in and who are not part of the health care system, I need just to offer the reminder that the Health and Social Care Act was designed for the benefits of health and not necessarily designed to suit the requirements of the Civil Contingencies Act or existing local resilience forum boundaries. So that nothing is particularly coterminous. There are some difficulties to overcome, and we hope that in the main those will overcome. I think we need to work for the next year at least on the old adage that no plans survive first contact with the enemy. Therefore, during the first year, I'm quite certain that some of these arrangements will need some mid-course corrections. But I also, having worked with the old sets of guidance within health and had the opportunity to work with those drafting the current regulations, that I honestly think that this suite of guidance that's been issued over the last 2 or 3 months by the Commissioning Board through Department of Health, I do think they help to keep health at the vanguard of emergency planning. If we think back to 2005, then the majority of involvement with health in emergency planning rested more or less in and around A&E. Of course, we all know that's expanded under the Civil Contingencies Act, and I think this new suite of guidance actually takes the health system quite a bit further forward, and in some respects probably in front of some of the other organisations that are involved with the Civil Contingencies Act. As always, we have some new terminologies which we need to get our heads around, some 3, 4, 5-letter acronyms. First of all, NHS CB, that's the Commissioning Board, and that operates at 3 levels now, at area team level, at regional level, and of course at national level. ATs, the area teams, you will see on some of the commissioning documents already sent out, these are still referred to LATs, local area teams, although the revised format is to call them area teams, because when you look at some of the geographical size of these areas, they're nothing but local, that's for sure. There are 27 of those throughout England. And we move on to the Local Health Resilience Partnerships, the LHRPs, 38 in England. And as you'll see later, they have no statutory duties under the Civil Contingencies Act. CCGs are next, clinical commissioning groups, who are now responsible for commissioning the care for all of those of us in England under the new system. They have a designation under the Civil Contingencies Act, which we'll look at a little bit later on. DPH, Director of Public Health, these have been around for some time now, but mainly structured within the health system. Of course, now some of them have already done the migration. They are moving into the local authority perspective and will operate from within the local authority's area of responsibility. Public Health England, a newly formed group which comprises mainly of the former HPA. Again, that's operating at 3 levels. We have our local units, we have the regional level, and again, national level. We'll have a look in more detail at the last one as we go through the slides. AQPs, any qualified providers, these can be a mix of organisations. They're not necessarily just within health, they can be private organisations. Typically, I think the easy way to describe this would be for it to apply to anyone who takes the NHS dollar. Some of you will recall back in 2010, I think it was, October 2010, when the NHS published, in conjunction with the British Standards Institute, the PAS, Publicly Available Specification 2015, which is a framework for NHS resilience, and it was in that document that we first got the intonation that any organisation taking the NHS dollar would need to look into itself and fulfil the requirements of any guidance that applied to providers of health care. So from the Commissioning Board's perspective, those are the 4 regional areas, and I think it's not unfair to say that although maybe there's been some grief, London's area at least hasn't changed. It's remained more or less static. Big changes, of course, for the other 3 areas, the north, the south, and the Midlands and east of England. Again, fairly large regional areas. I haven't done the maths myself, with the exception of one, the NHS south of England, which has an area that runs from the Isles of Scilly to the Isle of Sheppey, spanning some 370 miles. So we can see that these are fairly large geographical areas. And it's also important to note in terms of EPRR, Emergency Preparedness, Resilience and Response, that these are probably almost coterminous now with the REDS, Resilience Emergency Division of the Department of Communities and Local Government. So we have a little bit more synchronicity there, that they cover the similar regions. So that's the Commissioning Board at regional level, and of course you all know that at the higher level is the main board that reports directly through to the Department of Health, and we have a schematic a bit later on just to clarify that. So look at some of the area teams. There are 27 throughout the United Kingdom, throughout England. They have the remit to ensure the local management of the health resilience partnerships. They need to coordinate with PHE and also with the transfer of the department with the directors of public health. They've also got to engage fully with local government partners. And you'll see a little bit later on as well as an example I've got, it's even more critical, this particular involvement with local partners. It's got to look after the governance of the NHS in terms of its integrated plans for emergencies. They're not just these no-notice dramas that occur, that's also plans in place for specifics such as CBRN, pandemic, as well as the normal pressures that are applied on the NHS system at any time throughout the year. Joint emergency plans, again, that's sort of reinforcing the fact that they've got to work closely both with PHE and local authorities. And finally, they are to ensure that the Commissioning Board is fully involved in discharging the functions and the duties at local level throughout England. Just some maps to give you an idea. That's some maps, and the circle I'll come to a little bit later. That's a map showing you the relative LRFs. On this one it's included the 3 within Wales, but you can see roughly where they sit out, coterminous with policing boundaries. The next one shows you a good view of the area teams, and you can see if you switch between those two particular screens, under the circle, the variation between LRFs and the area teams. I think from memory there are probably 3 area teams in England that will have to communicate, connect and liaise with 3 SCGs or 3 LRFs. So that's a bit of a challenge for the area teams in managing that particular piece of work. And there you go. That's just a map to show you the LHRPs that are now in situ. And the one that springs to mind is where I'm speaking to you from right now in North Yorkshire. You can see that's a pretty large LHRP taken in North Yorkshire Police Service and Humberside Police Service too. So, the LHRPs are strategic planning. They have no specific remit under the Civil Contingencies Act or any other act. So they are strategic planning, and they can be co-chaired, and either of the co-chairs will go forward to represent that planning group at the local LRFs. And as I've just said, that could be 1 or it could be up to 3 different LRFs that LHRP represents. There's the wiring diagram. You'll see that the partnerships can be co-chaired by a nominated executive, the lead exec for the area team commissioning board, who has the responsibilities for pressures on the system, and also with the lead, a nominated lead DPH from one of the authorities within that region. When we look at who attends that partnership, then again that's for negotiation with the commissioning board exec. What I've shown underneath is just a specific example. It's not necessarily the only example. We have ambulance services, we have the clinical commissioning groups, acute or foundation trusts, community services, and again the phrase any qualified provider. Now some examples of that may be some of the private providers there are now in place, and we think particularly of the big ones like Spire Health or Bupa. We can also think of Virgin Healthcare or Boots Medicare. Anyone who takes the NHS dollar may be invited to serve on the Resilience Partnership Board. I think we need a degree of pragmatism. Everybody who takes the NHS dollar has a certain criteria to meet, and I think when we look at them, and I give you some examples, it may be that not everyone who takes the NHS dollar needs to meet every one of the requirements under the EPRR. So there will be some decision making to reach there. And again, as you will probably know, this will be teaching Granny to suck eggs. Of course, the ambulance service, not only will it be invited to sit on the LHRP, but of course it has under its own right a seat at the LRF table without being represented by the rest of the partnership. So, sort of recap, it is a strategic forum for health sector organisations. It looks solely at preparedness and planning and reports up to the LRF. It has to show that it is supporting the NHS, both through the Commissioning Board, through Public Health England and through the local authority colleagues. Co-chaired by a nominated area team director, a lead exec, and I'm sure they've all been appointed now, together with a nominated lead DPH. Just a word about the DPH, and most of those will take this experience with them into their new local authority remit. They will hopefully gain full understanding of the new legislation, and of course the principles of integrated emergency management, more about which a bit later when we talk about core standards. Full knowledge about the availability of technical and professional advice should it be needed. They will be possibly required to support the stack when and if that's called for. Excuse me. They should be fully au fait and clear about the EPR responsibilities specific to DPH, and there is a range of competencies out there for them. Understand the roles of their partners, particularly in health, but also in some of the other major players, particularly when it comes to the response arrangements. Experience of strategic leadership in a crisis, and again, more about that shortly. And of course, very good knowledge of local and, I would suggest, also regional systems and relationships. The new responder statuses, well, the Commissioning Board at all of its 3 levels are Category 1 responders, as is Public Health England. Local authorities are not changed, obviously. They take in the DPH, but they are Category 1 responders anyway. And it says there, and this is taken directly from the guidance, that the majority of NHS provider organisations, well, I'm not necessarily, whilst it is a majority, obviously, there are some notable exceptions, but they're still covered under the guidance rather than the Act, and that would be mental health trusts, for example, hospitals that don't have emergency departments, but they're still, as previously, expected to work towards the spirit of the Act and to within the guidance. Another big health provider which isn't included, and again I'll mention separately later, would be the care home stroke, rest home stroke, nursing homes, if any of those take the NHS dollar. Of course they come under the nature of the guidance, but of course not under the Civil Contingencies Act. The new clinical commissioning groups are Category 2 status, and again, we'll see how their role evolves as we go through the first year, but obviously they would need to have a say in the financing of EPRR arrangements and, of course, any unusual responses, the provision of additional resources should they be necessary. So they will be setting up their own responding statuses, and that will be interesting to see how that pans out across England. No collective status at all. We've mentioned the LHRPs, and of course, just again, a reminder that although there is a requirement for a stack, it has no specific responder status. It's an advisory body drawn together. In terms of response, the Commissioning Board are responsible for providing health leadership at NHS Gold or SCG. And I think you take note of what is actually said there, for providing health leadership. My understanding of that doesn't mean to say they have to be there on each and every occasion. They have to make sure someone who can provide that leadership would be available. And of course, in some of the areas where this Commissioning Board in the area teams are responsible or responding to more than one SCG, then that does provide them with some more complex problems in terms of putting together operational rotas. The response does require complete cooperation with the DPH, and that relationship, although it's between 2 different government organisations now, really does have to remain strong and fully conversant with each other. As before, I should have taken these out. I do apologise. You've seen these, so I'll quickly go through the maps. Bringing us to a memorandum of understanding, because the Commissioning Board will need at times to speak for and on behalf of different health organisations, there needs to be a memorandum of understanding in place that will allow whoever sits at an SCG has the devolved authority to commit their resources. as you will probably know, this does not necessarily, this does not in no way does it resolve each organisation for their own individual responsibilities under the Civil Contingencies Act. So it's necessary for memoranda of understanding to be around to allow and agree for a nominated executive to sit at an SCG to use the powers, the devolved authority in them to manage the health response. So have a look for that one. It's on the Commissioning Board website. Hopefully this is a model that's being used up and down England rather than people trying to fashion their own or craft their own document. The Commissioning Board, in terms of the new framework, command and control framework, there is a document out now which you can again download from their website, which is the standard for command and control within the new health sector. One of the new requirements is for organisations to be able to establish an Incident Coordination Centre, an ICC, a new three-letter acronym formerly known as control rooms. And they're also looking to use the terminology of incident director rather than a gold commander or whatever. It does seem to fit more in tune with health's daily operations, and it's very easy to migrate through that to incident management, whether it's a no-notice drama. So the guidance speaks of incident directors rather than a health commander. There's also in there a requirement, as there was in some of the older documents, so there's not really a big change here, but there is a requirement for trained support staff. So it's expected that whoever supports an incident director within the Incident Coordination Centre, that they have some formal training to be aware of what their roles and responsibilities might be. The quick and instant example that comes to mind would be logist, but we can also read into this particular coordination centre that you might need information managers, you might need an incident coordination centre manager. There are lots of things that go into that. So I would suggest that those responsible for putting plans together for an ICC takes time out to have a look at the document. One of the other things the document is keen to put into place now, and I've seen some pretty good examples and pretty bad examples of my work in and around trusts up and down England of what a control room looks like, but they're very, very keen now to move the decision maker or makers, depending on how many are in the team, to move them from the centre of activity, from the noise, if you will. So you will see that incident coordination centres, they are commended now to have a quiet area aside from the often mayhem of a control room, where those needing to make serious decisions can do so without interruption. And in terms of defensive decision making, this would be quite a good thing to be able to demonstrate. So have a look at the document. It's on the Commissioning Board website if you already haven't had it downloaded. Back to this any qualified provider. You're probably aware that in every one of the new standard NHS contracts now, organisations are required to acknowledge that they have in place plans that will allow them to support the NHS through difficult response times or disruptive challenges. This is where I think health's gone a little bit further than others in the past, and the next slide I hope will demonstrate that. But there is a need now to name an accountable emergency officer within each of the organisations who take NHS funding to be known as the Director of EPRR. And as I said earlier, my example of this would be rest or stroke nursing homes that often take NHS funding, and the question to people now is, how much aware are they of the new responsibilities that come under EPRR? And I would suspect that there's a huge majority are not up to speed on this. So maybe we have some work to do there in the not too distant future. So, as the Director of EPRR, the guidance suggests that it should be a board-level appointment, wherever possible supported by a non-executive board member. The nominated or named person should have executive authority to act, meaning in effect that any difficult decisions they should have the full authority of the chief exec to take without reference back. They have to ensure compliance and to give assurance to the commissioning board that their particular organisation is able to meet the requirements of the guidance under stress conditions. They should be properly resourced to do that, and they should be able to demonstrate compliance with the current legislation and guidance and any that might be forthcoming. I mean, this is where I would ask you to consider a layer of pragmatism over this, because there are lots of qualified providers giving healthcare across the system who you might think that this level of involvement may be unreasonable and far from practical. And I would use people maybe in the mental health sector who provide small organisations, probably 2, 3, 4 people, who provide either the talking therapies or maybe physiotherapy, that sort of thing. How hard you apply this level of EPRR onto those organisations, I think, would deserve a good level of looking at and a high degree of pragmatism. So, whilst it does apply to all, I think we need to take some value judgments in how we apply that. The inevitable wiring diagram, I'm sure you've seen it. I don't know whether you think it's better than the one that appeared in the Department of Health's strategic document, December 2007. It's probably not quite as complex as that, but along the bottom right of your screen you will see the providers and the commissioners and the ambulance services. They feed up, and this is the planning element of it, not the response. They feed up and have their discussions at the LHRPs. On the right of the screen, and the dark blue if you're looking in colour, if you're not, the dark blue is next to the light blue. We've got our 3 levels of commissioning board, the area teams, the regional offices, and of course the commissioning board directors who report directly through to the Department of Health as their lead government body. To the left of the Local Health Resilience Partnership, we have the PHE structure, we have the local centres, then we have the regions, and again their national office. Once again, their lead government department being the Department of Health. And finally, over to the left and on the red side of things, we have put in place there at the bottom the multi-agency response, and whilst I'm aware that there are Maritime and Coast Guard Agency perhaps in there, there may be there will be the police service and others. We've put them on that side. They report up to the REDS, the Resilience Emergency Division of the Department for Communities and Local Government, and who report up to their lead government department, which is the DCLG. And you'll note that in times of emergency, in the planning phase, they would both go through to the National Security Council. So that's the planning wiring diagram. We move on to the response diagram. Little change, as you'll know at the bottom, we have our provider and commissioner services. The right is still the commissioning board. The big gap in the middle, of course, is the LHRP have gone. And the other minor alteration there is the LRF has morphed into the Strategic Coordinating Group. More or less, all else remains the same. We have the ability for the stack to feed into the SCG, and I've got a couple of slides just a reminder about what our stack should be doing. We've also got SAGE, Scientific Advice to Government in Emergencies, sat at the top there, and the National Security Council for domestic incidents at least become the response committee you know best as COBRA, Cabinet Office Briefing Room. Just a quick look at PHE. I'm afraid there's a couple of slides on them which when I put this presentation together last week, I was still not quite fully familiar with how PHE are going to structure their responses. We know they've got units at local level where they will be dealing and inputting an awful lot of their expertise. They've got the regional hubs, which are more or less coterminous with CB and with REDS, and they feed through to their national centre down in London. So I would just, I'll show you the cover of the document in a minute. Have a look at PHE website and probably start to have a look at how they fit in now to the organisation. Of course, they will carry on the same responsibilities in chief as performed by the HPA. The stack is a significant resource which is made available to the SCG. Whilst the delivery of this is not easy, their responsibility is fairly succinct in that it has to provide the SCG with a single source of advice on matters technical and scientific. Couldn't be more simple, really, could it? How they achieve that, of course, is up to those who will manage this particular response, and that will fall to the remit of Public Health England, together with the assistance, I suspect, of lead directors of public health. Critical to the advice that they give, obviously, is the effect of any drama has on the health of the community which falls under their particular auspices. It can be activated by the lead responder through the SCG's generic procedures. These are well tried and tested response arrangements now. There shouldn't be any issue. Nothing much has changed other than probably the names of the responders, but that's all. So no change there, I think, is the message. I think one of the lessons learned from the stacks that have been in operation is that very often the advice required is often needed fairly quickly, and experience shows us that in order to get a fully functional stack together, this is going to take some time. So in the interim period, then the PHE will be responsible for giving emergency advice, if that's the right terminology, through to the SCG. And more often than not, the express professionalism may not be around in your particular area. Therefore, more and more access to teleconferencing and video conferencing needs to be arranged so that expertise can be joined from wherever, whether it be in this country or whether it be in another country. So have a look at this, if you will. This is their operating model, downloadable from their website. I don't think this, having had a quick scan through it the other night, I don't think this actually goes into the detail that we'll be looking for in the fullness of time, but I'm sure that will be available shortly. One of the things that sitting at Multi-Agency Gold or SCG, one of the things and the tools that's used to try and assess or analyse the effect on the community that you serve, they look to use an analysis tool. One of the common ones, of which there are dozens on the internet if you wish to have a look, but one of the common ones used is the steeple analysis tool. And you will find in the new framework guidance for EPRR that this particular model is commended for the commissioners and for NHS goals to make sure that they don't overlook any of the major concerns that we should all be considering when managing a major incident. So we look through the social, you can see them all there, political and the environmental measures. So have a look for steeple. That's the recommended tool in the analysis tool in the EPRR new guidance. We've also included this, which I was informed earlier today is going to be a joint model, known right now as the National Decision-Making Model. Credit to its development, I think, needs to go to the police service in the early days. You will find it included now in the new EPRR guidance, and is together with the use of a logist, together with the use of a good incident coordination centre. This model certainly helps those making critical decisions at Gold. I'm not saying the decisions are any easier, but following a model like this will at least give organisations the opportunity to demonstrate a calm, a logical format for how they reach the decisions. And remember, at the end of the day, the decision has to be reasonable, not necessarily right. So, once again, in the new framework guidance, I'm not sure you'll be able to find that just right now on the Commissioning Board website. Final invitations for comments closed about a couple of weeks ago, so I would suggest that maybe the document crafters down at DH will be formulating the final responses ready for publication. But that model will be in it. If you'll just give me 1 second, I've got a text box over. Okay, competencies, that's what it is. Again, I suspect another first in a way for health, in that they have set down model competencies. Again, you can see them. They have been published for Gold Commanders. Many of you will be aware of the competencies laid out by the Ministry of Justice, Skills for Justice, known as the National Occupational Standards. I have to say that in reaching these competencies for health, they have been drawn heavily from there, but why not? They are, in the main, interchangeable skills, and the gaps that are there are usually gaps in knowledge and awareness of a legislation. In terms of preparing themselves, commanders at Gold level have been commended to completing at least 2 training courses. One is the Strategic Leadership in a Crisis course, and the other is Surviving an Inquiry. And I would suggest that they would form part of the core competencies for a Gold Commander in terms of filling in the background knowledge. The other thing which has just been printed is a model job description and specification for emergency planning officers within the NHS environment. I see this as a bold move. It's giving a national standard which, to my knowledge, no one else has got in the responding community. So I think full marks for the Commissioning Board national planners in looking to set some standards, some minimum standards and some minimum targets for emergency planning officers across the whole of the NHS system, which I think is a very good step in the right direction. Again, if it's not on the website right now, and it probably won't be, it will be published very, very shortly indeed. So, excuse me. We've talked about legislation and guidance, and again, remember that when guidance is issued from such an august body as the NHS Commissioning Board, as an arm of the NHS, guidance carries almost equal weight with law. So we have the Civil Contingencies Act 2004, which you're aware about. You are also aware about the Health and Social Care Act, clauses 46 and 47, which are applicable. The National Emergency Preparedness Framework, that's the document you're all waiting for now. That's the new Emergency Planning Guidance 2005, if you will. That's the rewrite of that, and that will be available very, very shortly indeed, if it's not already out. The Command and Control Framework for the NHS, that's published, that's on the Commissioning Board website. Please remember too that British Standard NHS 25999 is now morphing across into the international standard 22301, and that's our business continuity arrangements. I've mentioned already the National Occupational Standards and the joint description, job description for emergency planning officers within the health sector. Just a timely reminder, I suppose, really, with these new practices coming out, with the new Incident Coordination Centre and supporting staff that work in there, you may or may not know that there are around 61 national occupational standards that apply to civil contingencies. A list of them is available on the Ministry of Justice website if anybody wants to find them. I do think, the last time I looked, which was a few weeks ago, they are looking now to charge for access to those documents. So I have raised that with the Department of Health, and they're probably looking at a workaround. You can imagine if every emergency planning officer within health organisations wanted to spend up to 700 quid to log on, it's becoming a very expensive arrangement. So I think if you can't get hold of that, just watch this space for a while before you commit to expenditure. There are some best practice competencies out there which you can look for. There are also now the core standards. The core standards are set for each of the NHS responders, so you'll be able to look at those standards, see which applies to your particular organisation, and then look to see whether or not you meet those standards. If you recall, previously there was just one core standard 24. Now you'll see there are a whole raft of standards which the Commissioning Board now will be looking for assurance that your particular organisation can meet. I've mentioned publicly available specification 2015, which is NHS Resilience. You'll all be familiar with that. You should also take note of PAS 200, which is Crisis Management. That's supported and co-published by the Cabinet Office, and again, earlier today, I was informed that that will shortly, later this year, be turning into a full British standard. So that then begins to up the ante a little bit on that. The next series of slides you'll be very happy that I'm not going to talk to, but for those of you who are anoraks in emergency planning, you will need to have a look at each of these slides. This is all the current guidance, legislation that's available to help you pull together plans, and it's quite a daunting task. I can't see how many slides, I think 3, maybe 4. So here we go. This is slide 1, slide 2. And again, you'll not be able to read all of these. I'm not expecting you to. Slide 3. I think that might be it, yeah. So have a think about those. What I would say to you about the whole of this presentation is that on this occasion, the EPC will make the slides available. They're going to be available in 2 formats. Firstly, tomorrow afternoon, from about tomorrow afternoon, you will be able to log on to the EP website and go through the audio again and a visual on the slides. And I've also been told that should any of you want to have a PDF of the slides I've used this evening, then if you submit that request to the college, that's absolutely fine, and they will try and meet that request for you. There are 2 names on the final slide that you can see there. My name and my colleague Verity Kemp, who between us put this presentation together. The contact details are there for you. If you do need to follow anything through, please contact either Verity or myself. Whilst you've got mobile phones there, it's much easier for us to work on email. So if there's anything you need to follow through, please just fire off an email and we'll get back to you as soon as possible.